I think there's a number of principles to keep in mind when prescribing to EASA participants, people in an early psychosis intervention project. First among them is to try to use as low a dose of medicine as possible, and I think this is important for a number of reasons. Number one, people in this age group generally don't like taking medications at all, so if you can convince them to take a medicine, they usually appreciate lower numbers with their medicine because it seems like less medication to them. Sometimes people even prefer taking a medicine like Risperdal, which the general dose is 2 or 3 milligrams, as opposed to something like Seroquel, where even a lower equivalent dose of 100 to 200 milligrams, that number might scare them off. A second reason I think it's important to use a low dose is the more medication you use, the more potential side effects the person will have. And one way to scare people from taking a medicine long term is to have them experience side effects up front. So if you go with a low dose up front, again, less side effects up front, you're probably going to have the person be more engaged in longer term dialogue with a psychiatrist about medication and taking the medication itself. A third reason I think that's important, very similar, younger people are more prone to side effects than general population of adults, especially the metabolic side effects of the antipsychotic medication. And besides them rejecting a medication that makes them hungry all the time and eating and gaining weight, there's also the physical health concerns. You don't want to set the person up for health issues like diabetes, cardiovascular illness, etc., years down the road. So that would be one of the important tenets up front. A second thing that I think is important when prescribing medication to people in an early psychosis intervention program is to not be paternalistic in your prescribing practice, to give the person, if not a voice, the voice, or at least the primary voice in what medications are going to be used and how they're going to use them. This might make it harder to get the person to accept medicine, accept a therapeutic dose of medicine, or even to engage in treatment at all if you're paternalistic. By giving them a voice, that gives them control. And that, again, in my mind, longer term will make them more likely to be adherent with medication and to benefit from it more so. A third tenet, I would say, in prescribing medication in this population would be letting people know up front that the medication isn't necessarily a long-term medication. We've had a number of people come into the program who saw another psychiatrist or another nurse practitioner prior to entering EASA, who was told after coming out of the hospital, let's say, you've now experienced psychotic symptoms, it looks like your diagnosis is schizophrenia, therefore you are going to have an illness that requires you to take medications the rest of your life, you're going to be vulnerable to having such symptoms all your life, and if it's bad enough, they'll tell them you're going to never go to school, never get a job, you should apply for disability now, and if you don't take the medication, it's going to be even worse than everything I've described. What a horrible message to give an 18-year-old, a 20-year-old, a 16-year-old. So letting people know up front, yes, I'm recommending medication, but hopefully we don't have to use this longer than, and that's where you get into a gray zone. 3 months, 6 months, the standard of care would be a year, but most people I found in EASA program, at least in our EASA program, don't want to take a medication for a full 12 months.